Good morning. I want to just have a quick moment to talk about logistics before I hand it over to Dr. Buber to introduce our guest today. But as everyone knows, we have had for a little while now a new system for getting CME credit for our grand rounds, and it requires you to text a particular number, but that number has changed from last year. And so some of you may know this already, but just to be super clear about this, text 11268 in the 60 minutes before, during, or after this session to make sure that you get recorded as present for the purpose of UW CME. And all right, with that, I'll hand it over to Dr. Buber.
All right. Thank you very much for joining us to this Friday's Grand Rounds, whether in person or online. As you all know, one of the most important or key factors in having a successful career in clinical cardiovascular medicine, I think, is having an excellent surgical partner. And I think that our demands from our surgical partners are almost impossible, right? We want them to be excellent clinicians, and we want them to be very good at knowing the material and read all the relevant papers in both cardiology and cardiothoracic surgery. And we want them to be able to take care of our most complex patients. And we want them to have good OR results. And we want them to guide us in managing our post-surgical patients and letting us know what to do with them. And so it's really difficult. And so this morning's Grand Round speaker absolutely checks all those boxes and then some. So I'm really honored to introduce Dr. Scott DEROO, who comes to us from initially went to medical school at the University of Michigan, and then did his cardiothoracic residency at Columbia University, joined the amazing group at Penn for surgeries of the aorta, and then we were very lucky to have him join us here in 2021 at the University of Washington. I think that his hair was a little bit darker back then, but we're still happy to have it. And so Scott has been the author of numerous papers on thoracic surgery, and then a little bit zoning in over the past few years on aortic surgery. And over the past several years, he's been a member of our MTAP, or Multidisciplinary Thoracic Aortic Program, here at the University of Washington, where we meet once a week, every Thursday, to discuss very, very, very complex patients. And he just shines across and comes across as a very, very thoughtful and knowledgeable surgeon. And so naturally, he's going to talk to us about a very complex topic today, which I have a deep interest in with this, which is management of the challenging aortic valve. And I'm sure that we're all going to learn a lot. And so without further ado, Scott, thanks for joining us today, and thank you.
Thank you very much for that very nice introduction. I think I got this one, but I also really appreciated the assumptions you made about how much reading we are able to do as surgeons. That was a good start. I'd like to talk today about management of the challenging aortic valve. And as I was making this talk, I realized that maybe that wasn't a great title for it. And instead, it should really be management of the small aortic valve. And so I have no financial disclosures to report. However, I do have two additional disclosures, which is that I perform both surgical aortic valve replacement and transcatheter valve replacement, and I am a strong believer in the merits of both in the appropriate situation. So I want to start with just a hypothetical clinical situation to get us thinking about this problem. So imagine a 65-year-old female with severe symptomatic aortic stenosis. She has a trileaflet aortic valve and a small aortic annulus, which measures 320 millimeters squared, which roughly is a 19 or 20 millimeter annulus. Her BSA is about 1.8 meters squared. And she was physically active because she lives in the Pacific Northwest here and was running up to 30 miles a week as recently as 3 months ago, but has had to stop doing that, recently because she becomes short of breath and fatigued. So the question is what to do here. And yes, that is one of my dogs. And so whenever I'm faced with a difficult clinical problem, it's good to rely on somebody who has more experience, who's more well-read, and who's more intelligent than you. And so we'll kind of phone a friend and we can call Dr. Otto. And more specifically, we can refer to the guidelines that she is sort of the primary author. And so the first question we have is, well, does this patient qualify for any kind of procedural treatment? And the answer is yes. She has a class 1 recommendation for replacement of her aortic valve, given her severe symptomatic aortic stenosis. So now is where things get a little bit more complicated. What should we actually do here? What type of valve should we put in? And when we look at the guidelines for our two conventional valve choices, mechanical versus bioprosthetic valve, what you can see is that the only class 1 recommendations we have is that really we should have a conversation with the patient regarding valve choice and their ability to take anticoagulation. And then when we move into our class 2 guidelines, we see that they're largely age-based. And for patients less than 50, we look to a mechanical valve. For those between 50 and 65, you can kind of do a biologic or mechanical valve. And for those over age 65, it's reasonable to choose a bioprosthesis. And then in patients less than 50, there's this little 2B recommendation at the bottom for something called the Ross procedure, which is clearly something we care a lot about here at UW, but we'll defer discussion of that to a little later. And so that doesn't really answer the question about appropriate choice of procedure either, because now we have two different types of procedure. We have transcatheter valves, we have surgical valves. And so now the conversation gets even more complicated, and we should try to figure out whether we want to do a TAVR or a SAVR in this patient. And again, this is largely age-based when it comes to guideline recommendations. And so if you're less than 65 or you have a life expectancy greater than 20 years, which sometimes can be challenging to know, the recommendation is for SAVR between 65 and 80. You can do either TAVR or SAVR, and over 80 or with a life expectancy is less than 10 years, you're recommended to get TAVR. So this patient falls into this category here. And for those of you that watched the Olympics this year, when you get finished reading all these guidelines, you can feel a little bit like America's favorite commentator, Snoop Dogg, here watching the equestrian events. It can be a little bit overwhelming to actually know what to make of all this. And so when you kind of put it all together, you end up saying, well, between 65 and 80, you can kind of do almost whatever you want, but you just have to have talked about it with the patient and agreed that that's what you want to do. So clearly the guidelines are a helpful starting place, but they're not going to tell us exactly what we need to do for every single patient. So what other factors do we consider? So we'll think about age, annular size, surgical risk, our choice of valve, and our need for repeat procedure. And what we're really interested in are what are the long-term implications of our choice, and how will the choice we make today in terms of how we treat this patient impact their overall survival and their future in the longer term. So diving even deeper about what we really want to know, we're interested in the technical feasibility of a procedure. Can we do it? What is the risk associated with that procedure? Our short and long-term outcomes, and then our need for repeat procedures. So when we think about technical feasibility, this actually has become less of an issue in sort of the modern era. Both SAVR and TAVR are generally things that we can do for most patients. But just because we can do them doesn't mean we always should do them. A lot of the conventional things that were maybe challenging with regard to placement of a TAVR valve have been overcome with some of our most recent valves or adjunct procedures. A SAVR can be done in most people, but the issue is the risk is elevated as age goes up and medical comorbidities go up. So we think about procedural risk. This is not really a talk about risk. We have multiple ways to calculate risk. In general, the higher risk, the more appealing a transcatheter valve is. But we also think about our peri-procedural challenges and outcomes. And a small aortic annulus is what I think is one of the biggest issues in aortic disease today. And so why is this a problem? So in 1978, the concept of patient prosthesis mismatch was introduced, which at that time, the definition was when the effective prosthetic valve area after insertion into a patient is less than that of a normal human valve. And that's not a very specific definition of this problem. So over time, we went on to define this a little bit better. This is sort of the VARC3 definitions. And what it says is that if you have an indexed EOA, EOA being effective orifice area, and index meaning adjusted for height, less than a certain value, likely that valve is too small for you as a patient. And what we know is that BMI affects this value because there are different metabolic requirements of muscle and fat. And so you have to adjust for that when you're looking at whether or not somebody may experience patient prosthesis mismatch. So if your BMI is less than 30, we draw that line at an index EOA of 0.85. And if your BMI is greater than 30, that shifts to 0.7. And that's for any degree of patient prosthesis mismatch. And then we define moderate and severe with more stringent requirements here. It should be up just a little bit. So why is patient prosthesis mismatch bad? Patients that have patient prosthesis mismatch, or PPM, do worse than those without. So multiple studies have shown there's less regression of LVH, there's less regression of MR, there's less improvement in functional class, worse exercise capacity, increased heart failure rehospitalizations, increased incidence of structural valve deterioration, and increased perioperative and overall mortality. And so we see that here in a study, which is a meta-analysis looking mostly at SAVR patients. This is from 2016 that shows us that when we compare patients that had no patient prosthesis mismatch with those that had any degree, they did worse, both in the perioperative period and with regard to overall mortality. And what's interesting is that outcomes were worse in patients less than 70 years of age. As patient prosthesis mismatch became worse, patients that had severe mismatch actually had worse perioperative mortality and long-term mortality. Those with moderate mismatch actually did not have worse perioperative mortality. So this is another study, which is from the Partner 2 trial, looking at intermediate risk patients. And I've covered up the TAVR cohort right now because I just want to focus on the surgical cohort, which shows that people that had severe PPM did worse over a 5-year time horizon with regard to death or rehospitalization than those people that had either moderate or no PPM. There are different ways of predicting PPM. One is measured and one is predicted based on the size of the valve. And of the two, the predicted value is generally better, which is showcased in that another version of that figure. So if the annulus is so small, why don't we have native valve patient prosthesis mismatch? Well, first off, there's no prosthesis, but you really can't be built with an aortic valve that is too small for you. And the native aortic valve is a dynamic structure. It's really different than the prostheses we put in, which are generally fixed, rigid things, which are almost circular, not completely, but almost circular, whereas the native aortic annulus and LVOT is not. So it changes shape in systole and diastole. And it's not just the annulus, it's the sinuses, the sinotubular junction, and the whole aortic root complex. So this maximizes all the available space that we have biologically in that area. And a normal native aortic valve has a geometric orifice area of about 3 to 4 centimeters squared. If you look at that on echo, it actually ends up being kind of a little bit lower than that. Studies show between 2 and 3. But regardless, this is a lot bigger than the EOAs of a lot of the prosthetic valves that we're using. So when you just look anatomically here at how our normal aortic root complex is built, you can see the valve occupies very little of that territory around the aortic annulus and aortic root. You can see that left ventricular outflow tract is nice, open, and very patent. And when you look histologically at the junction between the valve and the aortic wall, what you see is that the valve is very thin. There's a hinge region to the valve itself, and there's not very much resistance to this valve opening and closing. And so the hemodynamics of this valve are sort of optimized, as is the use of space in that area. So what about prosthetic valves? So this is just looking at some of the different types of prosthetic valves that we have. And if you look in cross-section, on the left here, you have some traditional surgical valves. You have a homograft, a bileaflet mechanical valve, and a biologic stented valve. And without doing any calculations, you can just visually look and see that the orifice area of that stented valve is significantly less than the orifice area of that bileaflet valve or that homograft valve. But all of these don't perfectly maximize the area available for that aortic valve, because you have to have some way to anchor it to the patient. Many of them have a sewing ring, and in some cases you have those stents, which occupy space in that aortic annulus and LVOT. When you look at the transcatheter valves there on the right-hand side of the screen, on the top is a SAPIEN 3 valve, and on the bottom is an evolute valve. And you can see they're built very differently than the surgical valves that we have. They don't have that traditional sewing ring or those big stents. They're built on these sort of wire mesh cages, and as a result, the posts are very different. And you can see that the orifice area of those valves is probably a little bit better for any given size than for a surgical valve. So this is a busy table, but it shows the calculated orifice areas measured on echocardiography of various different surgical valves. And this is taken from a variety of different studies. But what you can see is that there's not really a standardization of sizing of surgical valves. A 23 millimeter EPIC valve on the top has a different EOA than a Magna valve, which has a different EOA than a St. Jude Regent valve. And so a 23 is not a 23 is not a 23 across the board. And when you look at some of our transcatheter valves, you see that those EOA values are actually not that different than some of the surgical valves. They're within kind of the same ballpark. But what I want to emphasize is that EOA doesn't really tell the whole story. EOA is not a static measurement. And this is data from a laboratory experiment where they took a few surgical valves and they subjected them to different flows, and they subjected them to measurement of EOA across different labs. And what you see is that EOA is flow dependent. And so they varied their flow from 5 to 30 liters per minute. And you can see that the largest discrepancies in measurement are close to the 5 liters per minute, which is a relatively normal physiologic resting cardiac output. And you can also see that over higher flow rates, those valves probably open up a little bit more, and so the EOA changes. And so, EOA doesn't necessarily tell the whole story. There are other factors, including hemodynamic performance of these valves, and EOA is not really a static measurement, but it's a good starting point. So what about transcatheter valves and this concept of patient prosthesis mismatch? Well, TAVR valves have a lower incidence of PPM than SAVR. And so this is, again, looking back at that 2021 study. And what they found is that when you calculate PPM based on 2 different methods, either measured or predicted, of which predicted is actually the better way to do it, we think. Measured relies on taking echocardiographic measurements, and we're probably underestimating the valve area when we do it that way. When you look at these predicted values based on what type of valve you're putting in, there's actually an absence of PPA with regard, or PPM, with TAVR valves, or at least severe PPM, when you compare them to surgical valves. And PPM in TAVR is not really associated with increased mortality. And this sort of makes sense when you consider that we don't see severe PPM with TAVR valves. So patients that have moderate PPM in either the surgical arm or the TAVR arm don't really have an increased 5-year incidence of death or rehospitalization versus patients that did. So how about looking at transcatheter valves of a small size versus transcatheter valves of a larger size? This is sort of more recent data. This just came out this year recently. This is looking at the STS TVT registry. And they matched 8,100 propensity match pairs looking at patients that got a small size transcatheter valve versus patients that got a large transcatheter valve. And at 3 years, the outcomes were very similar. So even patients that got a 20 millimeter, which is a relatively small size SAPIEN 3 valve, did just as well as people that got a bigger valve. But one thing I want to point out across all these studies, when you look at the demographic information, the average age of these patients is over 80. So that's a little bit tough to think about how we're going to apply that information to a younger cohort of patients. So how about TAVR after a surgical valve? So this is early data published in 2014, looking at transcatheter valves after surgical valve replacement stratified by a surgical valve size. This is something called the VIVID registry. And at this point, they only had 459 patients. They had 1-year follow-up. And patients that had a small surgical valve that then got a valve-in-valve TAVR did worse over 1 year than patients that did not. Somewhat expectedly, the same registry a couple years later looked in patients that had PPM prior to TAVR did worse after their TAVR. So you can't fix PPM once you have it by placement of a TAVR valve. So the first valve you put in is important. But again, the average age in this study was 79 years. This is a bit more recent data. This is partner 2 data. This is the continued access and valve registry data. There's 459 patients here. And with the modern generation of valves, what we do see is that even small surgical valves have less of an effect than they did in some of our earlier studies. So the transcatheter valves do a little bit better now. But again, the mean age in this study was 79. How about TAVR inside of a previous TAVR? So this is a study from 2020, which is a redo TAVR registry. And what we see is that if your first transcatheter heart valve was smaller than or equal to or smaller than 23 millimeters, your gradients are worse at 1 year than they are if you had a larger transcatheter valve to start with. And we know that having a gradient which is increased ultimately is not a good thing for patients. But when we look at 1-year survival data, it's relatively equivalent between patients that had a small size transcatheter valve and those that had a larger size transcatheter valve. So when you look at all this together, should we really just TAVR everybody? Is that kind of the knockout punch for surgical valve replacement? As kind of alluded to earlier, there are some significant limitations in these studies. Namely that there's limited follow-up. We know that over a 3-year period, most patients are not going to experience structural valve deterioration. That is a process that takes a little bit longer. We have really uncertain durability of valve and valve TAVR. And the biggest issue, I think, is that the people in these studies are old. It does not really reflect the reality for young patients with AS and a small aortic annulus. So we don't really have longer-term data here. And increased gradients are probably worse in young people. Younger people are more active. We know that gradients increase during exercise, and perhaps this will lead to premature valve failure. This is a large cohort study looking at an American cohort and an Australian cohort and looked at patients with native valve aortic stenosis of any degree. And what they saw is that any degree of aortic stenosis over a 10-year time horizon led to increased mortality. And this is just looking at those hazard ratios there. You can see that any degree of AS is bad for you. So there is very limited data regarding TAVR outcomes in young patients. And this is actually stolen from a study that was presented at the Society of Thoracic Surgeons meeting this year, just in January. This is not published yet. But what it showed in a study of patients in the state of California, age 60 or younger, was that patients that got a TAVR in that age group at 5 years did significantly worse than patients that got surgical aortic valve replacement in a propensity matched study. And so when you look at this, another kind of interesting thing that came out of this California State Registry is that of all patients that got an aortic valve under age 60, 47% underwent TAVR, which is a huge number. And there was a 2.5-fold increased hazard of 5-year mortality in the propensity matched groups in patients that got a TAVR in that age group. So this is really actually incredible data if it holds up, because this is one of the only examples I can see where this is not guideline-directed therapy. It really differs from what we would recommend based on those 2020 valve guidelines. So the crux of the problem really is in small annulus patients with a life expectancy of 20 plus years, does an initial small size TAVR as a first-line treatment increase mortality, and does this limit future treatment options? And can surgery as a first-line treatment option improve outcomes and expand future TAVR options? So what constitutes a small aortic annulus? There is no consensus definition. Historically, we've used about 21 millimeters as a small annulus. And that's based on some of that earlier data that showed small size valves may lead to worse outcomes. So when we think about small annulus, there are kind of two approaches. You can think about a TAVR first approach or a SAVR first approach. And you think about TAVR, these valves clearly have a favorable hemodynamic profile for any given valve size. However, there's uncertain long-term durability. There are possible concerns regarding coronaries, and you may restrict future TAVR options to smaller size valves. With the surgical approach first, there's definitely increased perioperative risk compared to a transcatheter valve. We know that. But by 1 year, outcomes are relatively equivalent. However, with surgery, we do have one thing that is a little bit different than transcatheter valves, which is the ability to enlarge the aortic annulus or improve the EOA of the valve we're putting in with a stentless valve option, or something called a Ross procedure, or even a supraannular root replacement. So in young patients that are, I would say, 70 years or less with small aortic annulus, an upfront surgical strategy may improve outcomes. But in order for this to be true, we need to place a larger valve than the native annulus will easily accommodate, or a valve with much better hemodynamics than the native annulus would suggest. This will allow for a larger size future TAVR and will optimize the hemodynamics of the procedure that we do now. So there are a few things that we can do surgically that allow us to get there. There's something called aortic root enlargement. There's a supraannular aortic root replacement. We can use something called a stentless bioprosthesis. We can perform a Ross procedure or a mechanical valve. And so we'll talk a little bit about aortic root enlargement here. So aortic root enlargement involves dividing the aortic annulus and physically enlarging it with a patch. There are multiple techniques for how we do this. If you're really interested in the differences between all of those techniques, you can come check us out in the operating room or just retrain as a cardiac surgeon. But it typically allows upsizing of an aortic prosthesis 1 to 2 valve sizes greater than pre-enlargement. There are some techniques which do allow for a little bit more than that, but in general, we can go from say a 19 millimeter valve to a 23 millimeter valve. So this is a video of what this process actually looks like, and it's a little bit confusing if you know the way the orientation here. But imagine that the patient's feet would be at the right side of the screen, their head would be at the left side of the screen, and the patient's on bypass, the cross clamp is on, and the aorta is open. And what you're looking at is the head of the sucker right there. Oh, you can't really see it, but that kind of shiny metal thing there is the suction device. And below that is the aortic valve there in the upper right side of the screen. So see if we can, yep. So that's the aortic valve, that's that suction. This is a cannula that would deliver cardioplegia. Here's that cross clamp. And so now we'll turn that off here, and we'll play this video. What we're doing is excising the aortic valve. You can see all the calcium on the leaflets there. And then we're sizing the aortic annulus, which size is quite small. And now with the scissors, you simply come down between the left and non-commissure, and you divide all the way through that aortic annulus into the aortomitral curtain. And then we extend that incision under the left commissure, the left portion of the aortic annulus, all the way over to that fibrous trigone beyond the nadir of the left sinus there. And you can see underneath those scissors there, that yellow fat, that's actually dome of the left atrium. And then we switch to the other side and we go over towards the non-sinus and we extend that incision all the way over to the anterior portion of the fibrous trigone of the mitral annulus, the aortomitral curtain, at or beyond the nadir of the non-leaflet there. And you can see by doing that, we've now created this big defect in the aortic annulus and essentially exposed a portion of the aortomitral curtain. We sort of do a crude sizing here, and then we go and we cut a patch, either of Dacron or bovine pericardium, and that patch is sutured into place along the aortomitral curtain there, running from fibrous trigone to fibrous trigone. And it's important that we pay close attention to how we suture this in, because once we're done, this is all going to end up below the level of our aortic valve. And once the heart fills with volume, this is an area we'll really never see again. So if you have a problem down here, it's really a big problem, and you can't fix it without going back on bypass and taking everything out. So now with that patch in place, you can see we're resizing the aortic annulus, and what you see is that it's now much larger. A portion, up to about a third even, of that valve sizer is now occupied by the patch. So we're drawing a line here on the patch to demarcate that area where the new annulus would be, and now we're placing our valve sutures kind of around the aortic annulus here. And the areas that serve as a junction between the patch and the aorta, we want to reinforce those. That's kind of a typical area where we might see some bleeding, so how we take these stitches really matters. But the idea is that you're going to end up with a significant amount of patch under your neo-aortic annulus. And now we're placing those sutures through the prosthetic aortic valve here. Those just are done kind of as you would expect in a mattress fashion, right around the whole valve. And once all those sutures are in place, we're going to slide that valve down into position. And you can see now how that valve sits in that aortic annulus. So we're now just going to go and secure that valve. We'll tie all those sutures, but you can see opening the valve just how much of that patch is under the aortic annulus there and how you've enlarged that annulus. So again, just securing the valve in place here. And ultimately, once that process is done, you can see how that valve sits. You see that patch sitting below the valve, and you see that nice widely open left ventricular outflow tract and aortic annulus. And you can see passing a relatively larger size sizer through the orifice of that valve. And you can see what the actual EOA of that valve may end up being compared to what we started from, which is significantly larger. And then in just a moment here, we will take the cross clamp off. You'll see the aorta here is just, we're finishing closing the aorta. Now that clamp is off, blood flow is restored. And you see that patch there at the bottom portion of the screen along with that suture line. And the patient's gone back to their own sinus rhythm and now has a larger size aortic valve in place. So what does the data look like for aortic root enlargement? Well, first, it's kind of absent from the guidelines. There's nothing that really tells us we should or shouldn't do this. But this is data from a relatively recent study from 2023 looking at the results of aortic root enlargement in a cohort of patients undergoing surgical aortic valve replacement. And what you can see is that patients that got aortic root enlargement, they didn't do any better than patients that didn't get aortic root enlargement. And so when you first look at this, this is potentially a little bit misleading. But when you delve into the data and you look and say, well, what size valves were actually put in, what you see is that they're relatively equivalent between the patients that got root enlargement and those that did not. And so what that means is that we were able to put larger valves into patients that otherwise would have gotten smaller valves, such that patients with a smaller aortic annulus ended up doing just as well as those patients that did not have a small aortic annulus. So the issue is kind of how we think about the control group here. This wasn't really a study that said, if you have a small aortic annulus, how do you do if you have a root enlargement versus no root enlargement? It basically showed that we were able to do a more complex procedure, enlarge the aortic root, and have equivalent survival between the groups, one of which underwent a more complex procedure than the other. So aortic root enlargement equalized survival in a group that was expected to have worse survival. So what we can take away from this here is that root enlargement can be performed safely. It leads to implant of larger size aortic valves, and it may lead to a larger size future TAVR valve. However, it is rarely performed. It's hard, and it can lead to complications if done poorly. As you may expect, there is a reluctance amongst a lot of surgeons out there to transect a portion of the aortic annulus, go down into that aortomitral curtain, and rebuild it. So it's something that I think we need to have a little bit more increased emphasis on. And to illustrate this point, this is data from the five-year data from something called the COMMENCE trial. And this trial looked at basically a new treatment for aortic valve leaflets, an anti-calcification treatment. And it took a valve that has kind of been on the market for a little while, and then it just applied these new leaflets to it. And this is kind of the beginnings of the valve that we use now as the Inspiris valve. The sewing ring was a little bit different on this, so it can't totally be called the Inspiris valve. But the point is, this is a relatively contemporary series using a surgical valve that we kind of use now, looking at what people do. And this was from a study looking at the outcomes of patients that had a bicuspid valve versus a three-leaflet valve, who then went on to get a prosthetic valve replacement. As expected, that didn't really show any difference. But the real interesting thing about this study had nothing to do with the bicuspid versus three-leaflet patients. It was a good study to look at what size valves are actually being put in the contemporary era, and to look at the 5-year outcomes of surgical valves. And so when you look at this and you combine that data into one group, and interesting. And we chart that in a bar graph, what you see is that almost 20% of all patients in this study got a size 21 surgical valve. There were some patients, thankfully not very many, that got a 19 surgical valve, which is probably predicted to give you at least moderate PPM for most patients. But over half of this cohort had a 23 or smaller surgical valve in place. And so when you look at the results section here, what they report is that root enlargement was performed during for only 1.9% of participants in this study. So this is underutilized. And I think referral to a large specialized center with expertise in this technique is merited. And a larger valve at the index operation, without question, will lead to a larger transcatheter valve at follow-up. So switching gears a little bit, one of the other techniques that we have to place maybe a larger valve is to say, well, we're limited by what size aortic valve we can put into a native aortic annulus, but how about if we replace the entirety of the aortic root? This is, again, not a guideline-directed therapy, but it's something that is talked about in our profession. And it allows for placement of an aortic valve above the level of the native annulus. And so while the EOA of any valve size isn't going to get better, you can put a larger valve by placing it above the native annulus. This removes the contribution of the sewing ring, and to some extent even removes the contribution of those struts in a stented valve. And so to illustrate this point, this is a picture comparing a partially intraannular valve placement on the left to a completely supraannular valve placement on the right. And what you can see is when you have to account for those struts and a portion of that sewing ring, you just can't fit as big of a valve into the same opening as you can when you place an aortic root. And so this is a picture of the Mngt device, which is a root replacement device on the left here versus an Inspiris bioprosthetic valve on the right there. And what you can see is that on first glance, that Mngt device has a much larger sewing ring than that Inspiris valve, but it actually doesn't matter because none of that sewing ring needs to go into the aortic root, and it doesn't need to fit into the annulus. All of that can be supraannular, and that sewing ring really is great because it just seals very well. We don't really see a lot of bleeding with that, and you can maximize the EOA of the valve you choose because essentially you can match it directly to the LVOT and the aortic annulus. One of the challenges with traditional stented aortic valves is we don't want there to be paravalvular leaks through these valves, which is accomplished by having a sewing ring that you will seal effectively. But for every amount of fabric or material that you add to that sewing ring, you're decreasing the EOA of that valve. And so that Inspiris valve that you see there tries to strike a balance between those two things with a relatively small sewing ring, but you still have to account for the struts and that sewing ring. So by simply doing a root replacement, we can increase the EOA of the valves that we are able to put in. So there's another type of root replacement, which is called a stentless aortic root replacement. And this is probably less commonly done now than it was before. But these valves have a very large EOA. They don't have the stent component, and many of them don't really even have the sewing ring component that can contribute to placing a smaller valve. So this is a picture of something called a freestyle aortic root. And it's actually just the complete aortic root from a pig, which has been harvested, decellularized, treated. You can actually see the coronary arteries have been ligated there. So this would be one and this would be the other. And then a sewing ring is put on the bottom. It's not really a conventional sewing ring like you saw in those stented valves. It's really a piece of fabric to sort of help strengthen that area. And this can be placed as a supraannular root. And what you can see is that it looks like a native valve because it is a native valve. But it is, it's been treated and it's been processed. And the major benefit here is that this is actually a very pliable device. And so when you place the sizer into the aortic annulus and you say, okay, this sizes to a 21, you can actually upsize, even with the manufacturer recommendations, by 1 or 2 sizes. So you can go from a 21 implant to a 25 implant, which sits, you can see that valve actually sits above the level of that ring. And so you end up placing a very large valve in there that has a big EOA and has better hemodynamics than some of the stented options that we have. So aside from the fact that this is a more extensive procedure than placement of a stented valve, why do we not just consider stentless root replacement for everyone that has a small annulus? Well, you can see this is actually not a picture of a freestyle root. It's a picture of a stented valve. But over time, things calcify. And in particular, these freestyle roots tend to calcify, and they calcify pretty badly. And that's just an illustrative picture of what that dystrophic calcification looks like. It can be very impressive. And just last week, we operated on a patient that had a previous freestyle aortic root. And I'll just play this scan here, and you can see that is totally circumferentially calcified there. So historically, in patients that were going to need repeat procedures, it was a challenge to operate on these people that had a previous freestyle aortic root. So the other issue with these devices is that they fail in somewhat of a less predictable fashion than patients that have a stented valve. So traditional stented aortic valve replacements fail with a progressive aortic stenosis. In the freestyle root or some of these different porcine valves, what can happen is you can have sort of slow failure, which is then complicated by very quick failure when you have a leaflet shear off or tear from its connection to that aortic wall. And so this leads to severe acute aortic insufficiency in some patients, and this is poorly tolerated. So that's one other drawback of the freestyle device, but these do tend to fail late. They tend to fail 15 to 20 years after implant, and they're a good option. So specifically in patients that are in that kind of 65 to 75 age range, who may be very healthy and have a lot of good years left, a freestyle route may be a lifetime solution for that patient. Also, these certainly can accommodate a transcatheter valve in the future here. So let's put this all together in one spot in terms of what these EOAs look like for some of these different valves. And what you can see here is just the EOAs for a couple different surgical valves and transcatheter valves for any given size. What's a little bit misleading here is that they all size differently, right? So you may be a 23 in a Paramount, but you can fit a 25 or 27 Connect, or you might be able to get a different size mechanical valve. And even amongst our TAVR valves, if you look at the 23 Sapien versus the 23 Evolute, they have different EOAs, but they also size differently. So patients that usually get a 23 Sapien often size for a 26 Evolute valve. And so it's really hard to just compare. So it wouldn't be a surgical talk here at UW without mention of the Ross procedure. So this is not a new procedure. It was pioneered in 1967 by a guy named Sir Donald Ross. And this is a procedure where the pulmonary root is harvested en bloc and transposed to the aortic position. Like any root replacement, the coronary arteries are reimplanted in the neo-aortic root. And then we use a cadaveric pulmonary homograft to replace the pulmonary root and the main pulmonary artery. And so this is really different than our other options for valve replacement, because this is actually a living substitute for our aortic valve. And just like we saw with that freestyle route, but to even a much greater degree, you maintain the excellent hemodynamics of sort of native valve architecture. So this is a video of what this process actually looks like. So again, we're looking, the patient's already on bypass. The feet would be down to the right, the head to the left. And we're looking, the pulmonary artery is open. And what you see is just into the right ventricular outflow tract here. And so when we go and we play this video, you're looking at the leaf foot of the valve right there. And now this is in a move that would be considered lethal in most other circumstances. We're taking a right angle and puncturing the free wall of the right ventricle, a couple millimeters under the pulmonary valve. We're now just kind of drawing in where that valve would sit. And now the right ventricular outflow tract is opened sharply. And the goal is to stay just a few millimeters below the level of that valve. Once you can kind of see what you're doing, the pulmonary root is dissected away. So we're just using a pair of scissors here, transecting even more that free wall muscle of the RV. And now we're removing the pulmonary autograft here from the interventricular septum. So we're separating the RVOT from the LVOT there. And so once we have this out, now we're going to implant this as a new aortic valve. And so what you can see here, we're now looking at the aortic annulus. The aortic valve leaflets have been removed. And here we are taking stitches, which are just simple kind of proline sutures, which is basically fishing line. And we're doing them just kind of single sutures, and those go right in below the level of that pulmonary valve. And that's important to put them kind of right at that spot, because what that's going to do is put that valve right down kind of on that aortic annulus. And so you're going to remove the contribution of that little bit of right ventricular muscle that you have there. And you're going to have a wide open left ventricular outflow tract and valve that has excellent native valve hemodynamics. And so this usually takes about 40 sutures, which if you don't keep straight can become a real tangled mess. But those are all tied in individually. And then with the root unpressurized, you can see this thing it kind of just sits in that position, but it's hard to really appreciate the true architecture of it. So why complicate a simple aortic valve replacement? The Ross procedure is the only aortic valve replacement option that in young patients is capable of restoring normal life expectancy. And so this is a study published in The Lancet in 2010 looking at a Canadian cohort. And they looked at autograft, which is the Ross procedure, versus homografts, which is a cadaveric preserved aortic root versus a matched population that didn't have valve disease. And what they found is that even though the homograft has good hemodynamics, these also calcify over time. They become dysfunctional. And really, the Ross procedure, as opposed to a homograft, restored survival to that of a typical age and sex matched population. So when we look a little bit differently and we look at the long-term Ross outcomes versus mechanical AVR, which would be sort of a typical solution in this age group, what you see is that when you look out to 20 years, patients that got a Ross procedure did better than patients that got a mechanical aortic valve replacement. This is an interesting slide. This is taken from a study in 2000. This is an echo study. And what this does is looks at gradients of different valves versus indexed EOA, both at rest and at exercise. And so you have stented valves, stentless valves, which would be like that freestyle, root autograft, which is a Ross procedure, and homograft, which is the cadaveric aortic root. And what you see is that the autografts and homografts have some of the lowest gradients compared to stented and even to some lesser extent the stentless valves. And at rest, these gradients are pretty low. Some percentage of patients here do have patient prosthesis mismatch, which is demarcated by that line. But during exercise, things become much more pronounced. And what you see is that the gradients of the patients that got a Ross procedure remain really low, whereas the gradients of patients that had stented valves or even some stentless valves are significantly higher. And then a young patient over time, this is probably significant and may be part of the reason why we see improved survival in patients that got a Ross procedure versus some of the other options that we have. And then last but not least, one other option for a small annulus patient is actually just a mechanical valve. If you remember that slide looking at the cross-section of those valves, mechanical valves have a large EOA compared to other types of valves. And so you can see here for any given size, the EOA of the St. Jude Regent valve, which is a commonly used mechanical valve, is significantly better than a lot of the other options. And that just has to do with how that valve is designed in the tilting disc model versus having those actual pericardial or porcine leaflets. So in patients that can tolerate anticoagulation, a mechanical valve is a great option to improve hemodynamics without complicating your procedure. You have somebody that maybe you don't think they can tolerate a long bypass run, or you don't want to deal with the complexity of a root replacement or annular enlargement. Often the same kind of result can be obtained with a mechanical valve. And this is data from a 2017 New England Journal study, which shows that patients that got a mechanical valve who were less than 55 years of age had a statistically significant survival advantage versus patients that got a biologic valve. Now that disappeared once you got above 55 years of age, but regardless, a mechanical valve is a good option for young patients and specifically for younger patients with a small aortic annulus. So in conclusion, there's really limited long-term data regarding surgical aortic valve replacement versus transcatheter valve replacement in patients that have a small aortic annulus. A small annulus is really a complex problem, and there's not really one clear solution, and there's not a clear guideline-directed solution for it. And actually, with regard to root enlargement, I know for a fact that the Society of Thoracic Surgeons is looking at this and trying to incorporate this into their risk model because this is something that we talk a lot about. And I know this because we submitted a request to get all the data looking at root enlargement procedures done in the US, and they denied us, saying that they're actually looking at this internally. So when you think about patients with a small annulus, the initial procedure really should be undertaken with careful thought regarding follow-up procedures and what kind of effect this might have for a patient down the line. PPM appears to be a far more significant problem with surgical valves than transcatheter valves. If you have a patient that is not sort of on the completely younger side, a transcatheter valve has excellent hemodynamics and may represent a great outcome. I mean, we saw data that shows that in older patients, the outcomes of smaller transcatheter valves are probably pretty similar to the outcomes of larger valves. And a surgery-first approach in patients that are less than 70 years of age with a small aortic annulus and a long life expectancy is probably reasonable, but we don't have great long-term data to support any one particular strategy. We do have several validated surgical options, though, for implanting a larger size aortic valve, including root enlargement, root replacement, a Ross procedure, and a mechanical valve. And as mentioned before, in appropriate patients, a TAVR first strategy is totally reasonable. I think as we continue to see the data emerge for some of the low-risk patients and get some long-term data for TAVR, we'll have a much better understanding as to how these people do over time. So really, management decisions regarding patients with a small aortic annulus are best not made in isolation. So we have our heart team meeting every Monday morning where we talk about complex patients. And a lot of our discussion sometimes focuses on what to do with these small annulus patients and whether surgery or transcatheter valve replacement is an appropriate first step. And then if patients are deemed surgical, we have to figure out what is the best approach for that patient based on a host of other factors. And really, whatever procedure you pick to do, you have to do it well the first time around. The long-term outcomes don't matter if the short-term outcomes are bad. I think that's kind of one of those things that is often forgotten. And specifically, when we think about some of these more complex procedures in a setting where they might not be done all the time, we talk about root replacement, Ross procedure, annular enlargement. I mean, these are tough things to do. And so simply making a blanket statement or applying this to the guidelines and saying, well, this is good for patients, might not actually pan out to be true if it's performed by people that haven't done this a lot. And that's actually what happened to the Ross procedure in kind of the early to mid 2000s is, we looked and had some data that showed that it had slightly worse outcomes perioperatively than kind of typical aortic valve replacements. But really, when you looked at that data, what it came down to is centers that didn't do a lot of them had bad outcomes and centers that did much more of them. And the bar was pretty low, even 5 a year. The patients did significantly better. So when we think about this, procedural volume and institutional expertise matters. So at this point, we'll leave a little bit of time for questions. We'll wrap up and just a few pictures of life outside the hospital here and some of the reasons we love the Pacific Northwest. So thanks again for the opportunity to speak today.
This has been outstanding. It was a really, really good talk. And I think that the last point was very well taken and super important. How many we do and the first outcomes of the first surgery are so important. We all acknowledge that. So happy to take questions and make sure that you press the buttons when you ask them.
Great talk, Scott. This is hopefully just a hypothetical concern, but with aortic root enlargement, is there any long-term data to suggest that may precipitate pathologic further aortic root enlargement for these young patients later in life based on flow dynamics, or am I overthinking that?
No, it's a good question. So what we see is that the patients that are likely to dilate their aortic roots over time are people that come to us with aortic regurgitation. Patients that come to us with aortic stenosis, and most of this data is from the Ross population, but those are the people that are likely to dilate over time. The stenosis patients have the opposite problem. They're calcified, things are fibrotic. And you get so much scarring in that area, and you're actually fixing the annulus into position with that kind of stented valve. And so what you can see, and what we've seen in some of these bicuspid patients that get repaired, is that it's not really the annulus that may dilate over time, but you may have ongoing dilation of the sinuses or distal aorta if that's not dealt with. But now, if it's over 4.5 centimeters, the sinus or the ascending at the time of surgery, there's a 2A recommendation to replace that. So we don't really see people, dilating beyond their annulus there. What you can have happen though is if you get endocarditis or you get an infectious problem, having that patch in there is definitely a worse situation than not. And in patients that may have that or have some other issue or get a mechanical valve with a root enlargement, sometimes if you develop a pseudoaneurysm or some complication there, that's definitely worse than if you didn't have that situation. Dr. Otto.
Great talk. I think having you and Scott here really expanded our so even in the era of TAVI, there are people where surgery is the best option. So my question though is of like the superannular versus the annular insertion of the valve. Is there anything we need to look for on echo or clinically? Is it sewn into the same tissue? I mean, is there any risk of that dilating or causing a problem?
Yeah, it's when you do a standard aortic valve replacement, whether it's superannular or intraannular, you can't really decide that. It's kind of decided for you. All the valves are placed a little bit superannular. You have these pledgeted sutures that go below the annulus, but you're limited by that sewing ring and those stents. To really achieve a true superannular replacement that's going to give you a larger EOA, you have to replace the root. And that will allow you to get rid of the contribution from the sewing ring and that stent. So I don't think it's necessarily an echo finding, but it's really the decision about whether you're willing to do a root replacement versus not. There are differences in how these valves are made and where they're designed to be implanted. So when you look at the mechanical valves, the St. Jude Regent valve is actually a partially intraannular valve. But if you look, there's one made by Carbomedics called the top hat valve, which is a good name for a valve that is the only valve which is designed to sit superannularly. It's mostly defined by the characteristics of the valve versus what we're doing in the operating room. But that decision to do a root versus not do a root, that's where we can make the difference, and that's where we can implant a larger valve. Now, there are things that we can look for, though, that may make a difference in that decision. It's not benign to have to reimplant the coronary arteries. If you have a non-dominant right that is very small or challenging, that can be a tricky situation. And that may be a reason why you might want to avoid a root replacement and go with one of these other options where you're not having to reposition the coronary. And in that scenario, I mean, even a millimeter or two in the wrong direction might lead to compromised coronary flow. And then I actually had one case where the root was just so small that implanting a larger sized valve in a superannular root, these grafts are, they're a Valsalva graft, right? So they bulge out a little bit. It was just so large that it actually distorted the coronary anatomy. We have done this for a long time with freestyle roots, but freestyles are different than what these, stented valves are in these Valsalva Dacron grafts. And so, all of these factors, I think, become a lot more important. And it speaks to the fact that, if you haven't done a lot of root replacements in general, trying to do this for a small annulus patient is really tough, and you can definitely get into trouble.
Scott, there is one question online. For patients who come in for a redo aortic valve and have small annulus, what are the technical difficulties, I guess, when the previous procedure was a SAVR versus a TAVR?
Yeah, so there's data largely from a Michigan group showing that there's increased mortality with TAVR explant AVR. But I will say the caveat to that is that a lot of those patients in that initial study were quite sick. Some of them were in shock, some of them had endocarditis. It's definitely more complicated than if it wasn't there. I don't know that it is going to end up in the modern era being all that much more complicated. I think the jury's still a little bit out on that. We have a lot of experience replacing surgical valves. We have really good data showing that an isolated surgical aortic valve replacement after surgical aortic valve replacement does not carry an increased risk versus sort of that index procedure. And we can still apply a lot of these techniques, even if patients have had previous surgery before or have had a transcatheter valve before. I mean, we've taken care of patients that have had both, especially in young patients. So that CT scan I showed you of that calcified freestyle root, that patient actually went on to get a Ross procedure 2 weeks ago and has done quite well. So, you do have these options. We've done root enlargements. We've done all these things after TAVR explant as well. So I think it, has more to do with sort of underlying patient factors in terms of risk versus whether you got a TAVR or a SAVR previously.
Scott, really nice presentation. I tend to agree with your point that it's been transected 5 different ways that in patients who are going to receive a small TAVR prosthesis, the gradients are typically better. Hemodynamic performance is typically better in a superannular implant. However, looking at registry and trial data, there's not been hard outcome differences that are demonstrated. And I guess my question to you is, do you feel that that is more arbitrary hubbub generated to differentiate company differences in valves, or do you feel that there's something there that we may see in longer term follow-up that just hasn't been published yet?
I think there's a few things. So there's good data from this year now looking at the balloon expandable valves versus the self-expanding valves, showing that in a small annulus, the self-expanding valve people did a little bit better than the balloon expandable valves. We saw data showing that a small balloon expandable valve isn't necessarily worse than a larger one. But my problem is that all of this data is largely accumulated from older, higher risk patients undergoing TAVR. At this point, when we look at the large databases we have, they're partner 2, they're sort of the original partner study. And so a lot of these patients are really old and they're sicker, and there's a lot of confounding factors here. And so we don't really have great data for what to do with kind of younger, more active people that have a small annulus. And we don't know. I mean, we don't know in those people how long their transcatheter valve will last. If that California data pans out, we can see that maybe TAVR isn't the best for younger patients. I mean, that was propensity match data, but there are probably some questions as to why people are getting TAVR valves below 60 versus surgical valves. Is it all patient preference? Are there other factors involved? I think it's a really muddy picture right now. I do think there are probably some minor differences between the two main transcatheter valves that we use now in terms of hemodynamics and where things, how they may do over time. But I just don't know that we know enough to be able to kind of sort that out right now.
All right. If there are no other questions, this has been really, really outstanding. Thanks so much, Scott.